Good evening, everyone. And on behalf of AANA, I'd like to welcome you to the Wednesday webinar series. This week's topic we're covering is meniscus repair, preservation, and transplantation. My name is Aaron Critch from Mayo Clinic in Rochester, Minnesota. We'd like to recognize and thank our co-sponsors for this evening's program. This includes Arthrex, DJO, JRF Ortho, and Kaibo Medical. We'd also like to recognize that we're featuring faculty from the Mercury Study Group, that is the Meniscus Repair, Conservation, and Restoration Group. Just a couple of housekeeping items for everyone. It's important that you mute your computer audio and also turn off your video on the webinar screen. We are recording this and it will be made available. If you have any questions at any time, please feel free to use the chat graphic, find my name and type in your question and hit enter. I'm happy to integrate questions within the presentations, and also we'll have time at the end of the session this evening. So we want to make sure that your questions get answered and this is relevant for you. Delighted that we have three outstanding presenters with us this evening. The first is Dr. Seth Sherman at Stanford University. Seth is a team physician for the football team and also serves as the fellowship director. Next is Dr. Al Getgood at Fowler Kennedy Sports Medicine Clinic in London, Ontario. Al has a very complex knee practice, and we follow the science very closely, and he's had very much impactful research in this. And then finally, our president of AANA, Dr. Brian Cole, needs no introduction at Midwest Orthopedics at Rush. It's amazing that success is usually measured in the hundreds, but now he's over 1,000 papers, over 2,000 lectures, and over 20,000 surgeries. So we look forward to learning from his experience and his pearls this evening. Here's our agenda. Seth will lead us off talking about root repair and horizontal repairs. Al will then take over and give us his thoughts on radial and ramp tears. And then Brian will give us his thoughts and experience on his 25 years of perspective for meniscus transplantation. We'll present some cases if there's time, and we'll also take questions at any time from the audience. So please remember to use the chat function to send those in. Without further ado, Dr. Seth Sherman is going to start talking about root repairs and complex repairs. Seth, take it away.
Aaron, can you see my screen?
I can see your screen and hear you great.
Excellent. Well, I'm really excited to be here with you guys. It should be a great hour. My disclosures are online. So Aaron's kind of alerted us to these medial meniscus root tears, maybe an innocuous low energy injury. You follow these patients, and at 6 months, you might see rapid progression towards joint space narrowing, even bone on bone at a year, requiring a uni. So that's quite scary in a select group of patients. Brian's similarly alerted us to the valgus active female, like this patient with a horizontal lateral meniscus tear that was trimmed. And what we see is rapid progression towards bone on the PA flexion view and chondrosis. Again, something that should raise our index of suspicion. We looked at this in AJSM this year and showed a significantly higher reoperation rate after meniscectomy. That was in almost 30,000 patients versus repair. And meniscectomy more likely to undergo same-sided meniscus surgery, meniscus transplants, and total joint arthroplasty. So I'm here to challenge the classic dogma that these complex, horizontal, older, red-white revisions can't heal, and frankly, to try to expand our indications for what I'm talking about is really almost up to 50% of tears, so complex roots and horizontals. So medial roots are important because a root tear is equal to a total meniscectomy, and repair can normalize those forces. On the lateral side, Dr. Laprade has also showed us that repair can normalize these forces. Both medial and lateral roots also have implications in the ACL world with regard to sagittal plane translations and rotational stability as well. When we talk about horizontal cleavages, we're really talking about implications for leaflet resection versus repair. And frankly, if you look at a tear, you look at a partial or complete resection biomechanically versus an intact meniscus or repair, you can see profound differences. There are different types of root tears. Those medials, really more the older degenerative, lower energy trauma. These are isolated type tears. Laterals happen in younger patients, acute lesions, high energy trauma associated with ACLs. These medial roots we can talk about and consider fixing in certain circumstances. Those lateral roots in our young athletes with ACLs, I think we should fix at all times when we recognize them. On the horizontal cleavage tears, medial, again, older, degenerative, posterior horn, sometimes masked underneath some sort of a complex pattern. Lateral, these younger, can be post-traumatic with a painful parameniscal cyst, as you see in that MRI. Root tears require a high index of clinical suspicion. You need to be looking for it, and then you want to confirm by MRI and arthroscopy. It is likely seen you, so you must ask, have you seen it? There are clues on the axial, such as these radial splits. There's also good clues on the coronal MRI, vertical defects, extrusion of the meniscus, and the ghost sign on the sagittal. Lateral roots are way more challenging. They're less well visualized. They actually do not extrude in most cases, and up to a third can be missed on MRI, which means at our ACLs, we must be ready to fix these every single time. Here's a young athlete, an acute traumatic ACL tear. You can see here a complete avulsion of the lateral meniscus root that needs to be addressed to help restore rotational stability to that knee joint. So indications for roots, I think these acute traumatics, we should always consider fixing them. The chronic degenerative, our indications are clearly evolving. We must know before we go. That means your standard weight-bearing x-ray series every time and a mechanical axis view if you're really on the fence deciding between repairability or not. Medial meniscus root repairs don't work with uncorrected varus greater than 5 degrees, untreated chondrosis greater than 3, uncorrected instability, or with joint space narrowing. I think there's controversy, and we can discuss relative contraindications regarding obesity, whether patients can comply with a limited weight-bearing regimen, and whether we should have them undergo this if patients are not very active and high demand, if there are more sedentary patients. Rob Leprade showed us that restoring anatomy is key. If you're off by even 5 millimeters, that is going to lead to aberrant contact areas and pressures. We're just not getting the job done. So we really need anatomic reconstruction of the meniscus root. Fortunately, there are excellent proprietary systems that can get you in the ballpark and get you to the right spot, but there's nothing like anatomy to guide us. For me, I tend to use a retro-cutting device, as you see here, making a small socket at the meniscus root. Then we use a variety of suture passage devices. These days, I'm typically using luggage tab type sutures and suture tape, but we can discuss configurations, usually 2 to 3, depending on tissue quality and tear location. Suture passage, as you see here. So getting ready to shuttle, using a cannula so that we don't have suture bridges. And then it's all about just shuttling transosseous to the anterior aspect of the tibia, tensioning, making sure that that root is reduced throughout the range of motion arc, and then fixing with your desired fixation on the tibia. For me, at this point, it's suture anchors, although there's compelling evidence and more interest in button fixation that we may discuss. Moving to horizontal cleavage, really have had some novel all-inside techniques to provide what we call circumferential compression, or a hay bale technique. This is a young patient with a ACL and a lateral meniscus horizontal cleavage tear. So what we can see is that we can pass this circumferential compression type suture. You can march along and do this at 2 to 5 millimeter clips. I think my tendency now is to do more than I did in this video, but you can see after the ACL coming back, and you can see nice compression. You can put a biologic, if you so desire, inside that pita bread sandwich to help with healing. Here's a young athlete, painful anterolateral tear with a parameniscal cyst. And so for this one, it was an inside out technique, needed a 70-degree scope to really see that far anterior. And you can see flanking that with some attempts at biology to try to augment meniscus healing for this isolated tear. Root repair outcomes are quite good. The repair groups have superior subjective scores, less radiographic progression of arthritis, and 0 versus 35% conversion to knee replacement. This is a more recent study, 50 knees, 6.7% revision rate, significant improvements in patient satisfaction across the board, medial roots equal to laterals, young age equal to these older age patients. Horizontal cleavage repairs also have good outcomes, mimicking those other tear patterns, the more classic patterns, 80 to 90% good or excellent outcomes. Here's a study showing 30 patients at up to 8.5 years, 15% failure, 91% return to sport. This is the STITCH study. That was a multi-center prospective clinical trial, 91% success rate at 12 months, 8% reoperation rate, significant improvement in all patient-reported outcome scores, complete healing on second look needle endoscopy or arthroscopy in 10 of those patients. And lastly, Aaron wanted me to touch on flap tears. So here's a 17-year-old contact athlete, 1 year of mechanical symptoms and effusion. So in this young athlete, I'm going to try whatever I can to try to repair the meniscus. I think meniscectomy for that large flap may have significant detrimental effects and open up a Pandora's box for this athlete. So it's worth a chance. For me, I have all tools in my arsenal on deck. So the first thing I do is try to create an apical stitch to try to reduce that flap as much as I can. And you see here, now that kind of propped the tear up. And so I do an all inside underneath. And when I tension the all inside, now it sets me up for some circumferential compression. I can do 2 passes, one in the periphery, one in the central. And that really helps to close down that vertical longitudinal component. And then lastly, I placed another apical stitch, and I can pass this on either side of a previous suture, sort of like a rip stop, to help provide support, particularly in situations where there's imperfect tissue quality. And so this can take some time and doing, but I'm putting it in a relative position with good stability. And so I augment these with microfracture of the intra-articular notch, as you see here. In isolated cases, this is my go-to biologic of choice. And you can see I've trained the marrow elements to go into that lateral compartment. And we'll get a second look now at our flap tear of the meniscus. We can touch on rehab in a discussion, but for this one, I'm going to have a conservative rehab. I may not even move them that first week or so. I will do foot flat type weight bearing as I do for my roots, my radials, and my complex tears, which is very different than my buckets or my classic vertical longitudinals or the horizontals, which I do allow early weight bearing. And lastly, here's a 40-year-old nurse. She has a chronic ACL tear I'm fixing and this really complex medial meniscus tear. I'm very concerned if I take this out, we've lost our brake stop and our secondary stabilizer. I have the biology of the ACL to give me a boost, and I go for meniscus repair. Again, this is an all hands on deck, trying to piece together the periphery initially using a variety of all inside devices. You can see my first pass, which is quite peripheral. And then, we'll continue marching on, taking what the tissue gives us with a variety of either 1-pass circumferential compression hay bales or 2-pass suture technique. And then lastly, once I've stabilized the periphery, I use a couple of all inside sutures, as you see here, and try to get that meniscus in a relatively good position where it's now protected with the stability of the ACL with reasonable biology and a chance to heal. And here's kind of the final, what that meniscus looked like. You can note this was a very tight compartment. I am pretty liberal with trephination of the MCL so that I can see and do and repair these menisci. And so hopefully I've showed you that you want to limit your number of partial meniscectomies. They can lead to OA and poor functional outcomes. We want to have a high index of suspicion, particularly for these root tears. You need to know before you go so we can make good clinical decisions. And then we want to err on the side of meniscus preservation if at all possible. For me, this is the roots, horizontals, flaps, complex that I showed you here. Al's going to show you radials and ramps. And overall, if you learn nothing else from this hour, we want to try to save the meniscus. And I thank you very much for your attention and look forward to hearing the other speakers and having a good conversation. So I'm going to stop sharing now and hopefully we can move on to Al.